right, welcome everyone to our multimodality imaging conference. I'm Man Malafshi, and today we're going to talk about stress MRI. I see a lot of the general fellows are here, the advanced imaging fellows, and I am glad that there's good representation from all levels. So if I think back over the past, 5 or 6 years, there's been, amazing growth and improvement in PET in terms of volumes. And concurrently, we've done a little bit less stress MRI. So stress MRI, in the United States, is sometimes seen as a niche modality, but the reality is it's very powerful, and I will try to show you in which cases it can be advantageous to use MRI over PET. Now, comparing MRI to SPECT, I think is fairly established now in terms of the studies that were done, and it's largely superior in multiple aspects, which I'll show you also. We'll talk about the chest pain guidelines, which are now a few years old. We'll talk about methodology of stress MRI, evidence for utilization of stress MRI, and we'll show clinical cases as well. When it comes to the guidelines, and this is what we practice already, there's emphasis on selecting the right test for the right patient. And you're going to take into account the likelihood of the patient to having coronary disease, whether it's an intermediate to high likelihood or much higher likelihood, and then the patient's profile. Are they older or younger? Do they have extensive coronary calcium or not? Do they have known CAD or not, or known bypass grafts or not? And that's going to guide your selection in terms of anatomic versus functional testing. The guidelines, and I think general knowledge, have really emphasized that when it comes to stress testing modalities, the functional testing ones, there's kind of tiers, if you will, where each of them has their advantage, and then each of them would have their disadvantage. So stress MRI and PET may have an advantage in quantitative flow parameters, really nailing down scar extent and pattern of scar, and potentially identifying other causes for cardiomyopathy. Patients are allowed to have ischemic cardiomyopathy plus other conditions. Stress echocardiography and exercise testing and SPECT are preferred when you want to do exercise, although now we know with fluoroperidas you can do an exercise PET as well. And then stress echocardiography may also have an advantage for things like valvular disease assessment, diastolic function assessment. So no test is perfect, and you as a clinician will have to take a look at your patient and identify what test is the most ideal for them. But when you have older patients with existing disease, or when you have someone with a higher likelihood of a non-diagnostic CT, a non-fully diagnostic CT, you may want to prefer functional testing. And then when it comes to identifying who's the best person for which modality, we'll get into this a little bit later. So when it comes to acute chest pain patients without known CAD, there's a class 1 recommendation to doing stress MRI. Similarly, for those with known CAD or prior bypass, when you're suspecting myocarditis or MINOCA as an established diagnosis, really here you're going to prefer, or you're actually advised to do an MRI as opposed to SPECT, for example. And then with known CAD, the recommendation is 2A. The strength of the recommendation when it comes to functional tests and anatomic tests is very similar. So this is where your view of the patient's profile and risk factors becomes more important. And then your institution's ability or capability of performing these tests well and interpreting them well. And you'll see later on, many of the newer studies show findings that actually really give us a very strong clue that if you don't interpret these tests well, you actually also end up with suboptimal results or reduced accuracy or reduced specificity. So it's not just performing the test, it's also interpreting it. And you guys know from your experience with nuclear, there's a huge variation in the accuracy of individual interpreters to look at nuclear tests based on expertise level. The same applies for MRI. So when it comes to stable chest pain, it's also class 1 or class 2A. And when it comes to the advantages of MRI, it's higher temporal and spatial resolution. So temporal resolution is your ability to discern wall motion changes and abnormalities over time. And this is higher with CMR than it is with PET or SPECT. With stress echo, it's higher, but the challenge is the spatial resolution or your contrast resolution, your ability to determine segments, is going to be higher with MRI. So the end result is when it comes to, let's say, hey, I want you to give me what's happening in the mid anterolateral wall. When it comes to scar, perfusion, as well as wall motion, MRI is going to have an advantage over the vast majority, if not all, of the modalities. BMI is not usually a limitation, so you know this is a huge limitation with SPECT. It's alleviated with PET imaging. There's no ionizing radiation. You all see patients in the hospital now that have had multiple scans over just the prior 2 or 3 years. And you know, adding up these ionizing radiation scans will actually catch up to the patient in some. There's no dye preparation. So if you have someone with ischemic cardiomyopathy and known disease, well, if you're going to want the PET for viability, you're going to have to wait and you're going to have to do the dye preparation. And as you all know, that's not always very easily done for the patient. Whereas with MRI, you can do a stress MRI plus viability assessment with virtually no preparation other than just the caffeine aspect. You can look at coronary anomalies, although this is not really utilized. And then the viability assessment plus perfusion is done in one test. Importantly, there's a linear relationship between the image intensity on the scan and your contrast. So for the purposes of blood flow, especially at the levels of human parameters, this relationship is linear. Whereas, as you know, with nuclear techniques, there's a roll-off phenomenon where the uptake of tracer is not linear to myocardial blood flow at higher grades. And then time, although it may seem cumbersome, there's a reason in Europe they're doing a whole lot more stress MRI than SPECT. You can do a scan in 30 minutes compared to the half a day that the patient has to spend in the SPECT lab. Now, PET resolves that issue, but like I said, there's the other advantages of MRI where you need to select some patients to preferably do MRI over PET. And then obviously there's going to be cases where you're going to do PET over MRI. So that gets into why PET has grown so much, because it's highly convenient and highly accurate. So when it comes to MRI, what we do is we create slices of short axis of the left ventricle. Generally, we do 3 of these. And what you're going to do is inject contrast in the IV, and you'll acquire a series of images that look like a movie as a result. This will show you the contrast going from the veins into the RV and then into the LV. And then you'll see as the contrast washes into the left ventricle, the uptake of contrast by the myocardium. So as a result, if there's an area that is ischemic, it will not get as good contrast on first pass. And you'll do the same technique. You'll stress the patient, you'll give them regadenoson, and then you'll do a stress acquisition, and you'll do a rest acquisition, and you'll compare the two. So that part is similar to what we do in nuclear and echo. When it comes to the specific parameters or the sequences that we use for this, it's generally going to be what we consider it to be a fast acquisition, because you want to actually show that bolus of contrast going from the LV to the RV. So if you're acquiring at a frame rate of, I'm going to show you 8 images, well, you're not going to show that nice temporal resolution of the bolus getting into the LV, and obviously you can miss things as a result. So this is optimized to get fast imaging done. And then when it comes to the actual sequences, we'll focus more of that in our MRI conferences. But, I think for general cardiology conferences, this is kind of what you usually see. So we'll end up with a series of stress images, and then we'll end up with a series of rest images. You'll see that the patient is also breathing through these. We will also use motion correction algorithms to actually control for that. But the reality is for interpretation, it doesn't make a big difference, as you can see, when it comes to evaluating the bolus uptake into the. So this is kind of what a normal scan would look like. And this is how we generally do this. So you'll start by doing a rest acquisition, showing the LV function at rest. You'll do adenosine or regadenoson, followed by the stress acquisition with those 3 slices that I showed you earlier. And MRI, generally, we always reverse with aminophylline. and then you're going to do a rest perfusion scan. And then after 10 minutes, you'll do the LG imaging where you actually see the scar and the infarction. Now, what about dobutamine and exercise? These are kind of niche applications that are largely out of favor for when it comes to dobutamine. It's essentially done the same way we would do a dobutamine stress echo and has supportive data when it comes to sensitivity and predictive value. But the challenges with even dobutamine echo can be cumbersome on the patient, and there's relative and hard contraindications that will apply to CMR. But the challenge with CMR, you don't have a nurse sitting right next to the patient as you do with the dobutamine echo. So evaluating for things like BT and ischemic ST changes is a little bit harder, and that gets into why this is not as used as vasodilators. As a result of the tachycardia, looking at wall motion changes the same way you would do for an echo is also harder because the temporal resolution or the time resolution of the MRI is not going to be as good as echo. And then this I brought up already. When it comes to exercise, there is equipment that's magnet safe. It's primarily used in research arenas, and some centers also do it routinely. It has advantages, I think, for things like valve disease. Athletes also get these stress MRIs in certain institutions and other conditions. So when it comes to dobutamine, you'll do the rest acquisition, you'll do a stress scan, and then you'll do an LGE. And this is kind of how a treadmill situation would look like, where you would have a rest, you would do a regular treadmill stress test, and then as soon as the patient can go on, you'll put them on the table and you'll do the stress cine images. So you look at wall motion during peak stress. And then you can follow it with actual perfusion because you're still in that ischemic window. And then you'll do the same of the scan, the rest the same way. So this, as you can see, will take much longer compared to the regadenoson scan. So this is kind of how it looks, and you can tell from the video that it's an old school way. And you essentially have the patient run from the treadmill onto the scanner, and here you have to have really good techs and staff that can do this very fast. You can also get an ergometer that actually sits on the scanner, and this is very useful for those valve conditions, for RV function assessment with stress, etc. So this is primarily research at this point. All right. So interpretation of studies. This is a little bit different than perfusion scans or SPECT, in that we generally start by identifying if the patient has infarction or not. So you look at these delayed enhancement scans, and you'll try to answer the first question, which is, does this patient have CAD or not? If they have an infarction, then you made the diagnosis of obstructive CAD for the most part, right? Then you'll actually follow this by looking at the stress as well as the rest. For a stress perfusion series, and I'll show you more in the examples, you'll try to match the presence of the scar or infarction with a perfusion defect. If there's a perfusion defect that extends beyond it, you can look into peri-infarct ischemia. And obviously you can have, a stress perfusion defect, let's say in the circ, with infarction in the LAD. You'll start with this, and you'll follow by the stress perfusion, the stress acquisition, and then you'll compare the stress to rest. The bigger difference here is if you have a defect on stress plus rest, since you did the stress perfusion already and there's already contrast in the patient, the rest perfusion should already have contrast on board. Does that make sense? So if you get a defect in the same area, this may actually be an artifact as opposed to what you see on SPECT, where we call it a scar, right? If you see a stress defect but no risk defect, then you know that this is ischemia. And we'll get into this in the examples, but this is kind of a key difference. But doing it this way, as opposed to starting first with stress, then looking at scar, in this study was actually shown to be superior. So if you combine LGE first, followed by perfusion, you get very high sensitivity and accuracy and specificity compared to if you just do perfusion alone without incorporating the scar information, it's less accurate. A big advantage to MRI compared particularly to SPECT and older SPECT techniques is you can visualize some endocardial scars better. So in this study that included patients as well as a dog model, MRI identified 92% of artificially induced subendocardial infarctions compared to SPECT that missed only 20 or only identified 28% of patients. This is an older study, but um, the reality is for SPECT techniques, this number may not be as that much better nowadays. And this is only referring to small subendocardial infarct. So, a transmural infarct is hard to miss, but, these little infarcts in the OMs and the circ, as you all experience, can be missed on SPECT. Now, in the patient side, 47% of people with actual infarction were also missed by SPECT. So the high resolution of MRI techniques for scar assessment actually gives it an advantage over SPECT. This is just identification of infarct. But as a result, it plays into this arena when you can identify scar better or when you can identify infarction better. As a result, your overall assessment of CAD is going to be better. Does that make sense? All right. So um, let's talk a little bit about various randomized trials and some evidence for using MRI. So this is an older study, the CE Mark study that kind of established diagnostic accuracy of MRI against cath and then compared it against SPECT. People with angina and risk factors underwent all three tests, very high sensitivity and specificity of MRI. They were higher than SPECT. Positive predictive value and specificity were not highly different than against SPECT. And you see this was consistent across single vessel disease, left main disease, or multi-vessel disease. And this was also an older SPECT technique, which is, what kind of a key recurring criticism from the nuclear folks, against this study. And I believe it was thallium. The CE Mark True trial focused more on avoiding unnecessary cath or avoiding unnecessary angiography. So people with suspected CAD underwent CMR guided care versus perfusion guided care versus what the NICE guidelines at the time were. And essentially, both MRI and perfusion testing reduced unnecessary cath to the same extent compared to the current NICE guidelines. And, this is kind of now getting into, further establishing the ability of using stress MRI to spare patients, unnecessary cath. So we haven't gone into FFR and PET, et cetera. Prognostication-wise, with all stress modalities, there's now very powerful data sets, thousands of patients. This is an MRI one that included 9,000 patients with 1,500 events. If you have an abnormal stress MRI, it associates with um, um, future events of MI and revascularization. And this was regardless of whether you have no history of CAD, if you have established CAD, normal EF, abnormal EF, and then if you have existing scar or infarction or if you don't. The SPINS trial also looked into this, and it was a retrospective study. We were part of this already, actually. People with the chest pain syndrome who underwent an MRI with decent follow-up and looked at the primary outcome of death or MI. Also was a large study with 2,000 patients, and it essentially shows the same thing where you have a graded association with the primary outcome as well as secondary outcomes of revascularization when it comes to absence of ischemia and absence of scar, the intermediate in-between grades, so you have scar but no ischemia. And then as you may suspect, the worst group was the people with scar plus ischemia, the purple here. And later on, we had the MR Inform trial, which I believe was the latest RCT of stress MRI. This is guiding the management of people with stable angina, high risk of coronary disease, looking at MR perfusion testing compared to cath with FFR. And what they found essentially was non-inferior. So people were randomized to undergo a stress test versus invasive cath with FFR, and then essentially looked at presence of scar, like I was referring to earlier, and then the extent of ischemia. And if people had a positive scan, then they went to cath, obviously. So the endpoint was all-cause mortality, non-fatal MI, and then revascularization targeted at the index revascularization procedure, whatever that means. The revascularization rate was actually lower in the MRI guided group. compared to cath group, which I think you all would suspect you would find in a trial like this. But the outcomes were equivalent. You see the lines are essentially overlaid against each other. So it shows you that guiding care using stress MRI is not inferior to immediate cath with FFR. And this is with respect to actual hard outcomes. All right, let's talk about a few cases. So like I mentioned earlier, we first start with seeing what the wall motion looks like, what the LV function looks like, and then we look at scar. So this is a 56-year-old exertional chest pain, normal EF and wall motion. I didn't show you these in the interest of time. And then on scar imaging, she has no scar or infarction. So we look at the stress first, and we look at the rest. And what we do in the reading room is we also kind of slow this down, and we look at the individual segments and see the flow of contrast into the LV myocardium. And you see here that there's no perfusion defect, not in the basal slice, not in the mid slice, and not in the apical slice. So if I stop here, I showed you the scar information, I showed you the LV function, I showed you stress. Do you guys want the rest, or do you not care? Would you say if I just showed you, the bottom, I mean, the top portion of this scan, and I didn't show you this, would you call it negative, positive, maybe? Negative, yeah. So you can apply the same methodology that we do with stress-only SPECT in this context also. And actually, there are centers that do that. The advantage of the rest, like I said earlier, is in these kind of patients, we get what's called, or in stress MRI in general, there's an artifact we get that's called a Gibbs artifact, where you see kind of this very thin black line related to various explanations of physics of MRI. But when it comes to identifying these kind of artifacts, we use the rest information to see if it's a true perfusion defect versus artifact. So the rest acquisition in this kind of scenario really only helps you identify artifact versus not. If you're confident with your initial assessment and quality of the scan, you can actually do stress-only MRI. All right. And this patient underwent cath and she had no disease. Don't ask me why she had cath, but she had cath. It's my clinic patient. And all right, let's do this case. So a 60-year-old man, prior bypass, chest pain. And like I said, we start out with the wall motion changes. He has a normal EF, inferior wall hypokinesis. And you see on the scar images that he has a small infarction in the basal inferior wall. So you already know he has established CAD plus a prior inferior infarction. Let's look at the stress. So stress up top and then rest on the bottom. What do you guys think? Positive. And what do you think? Where's the defect? Yes, yes. So it extends from the basal to the mid and through the apical inferior wall. So it extends beyond what you see the size of the infarction. So this is existing infarct with ischemia, top of it. Peri-infarct ischemia plus ischemia throughout which vessel? RCA, yeah. And then on rest, you see nothing, right? So this tells you that this is real. If you had that tiny little thing, like I was mentioning earlier, you would suspect this is the only benefit of rest imaging. All right. So this is kind of the defect on, yeah. You would for nuclear techniques, but here what happens is since you gave contrast early on, it stays into that area. So that's why on rest, we don't use rest perfusion, that's done after stress to say, hey, reality here. This is kind of the main reason of that. So kind of here, it's kind of the opposite aspect. Say that again? Yeah, yeah. So I'll show you some data on this. Now there's quantitative MRI flow assessment. And we have that at sequence actually, where you get stress myocardial blood flow, rest myocardial blood flow ratio, same way you get with PET. And actually you can also get, graded ratios for epicardial versus subendocardial. So it's still, picking up in terms of utilization. There is some data to show that it's advantageous or additive to just visual assessment. But for the majority of patients, visual assessment is usually enough. Now, identifying coronary microvascular disease, for example, is doable with this, but like I was alluding to earlier, now PET has taken off more in this arena. And this patient has included RCA, as you guys see. All right. 86-year-old heart failure, referred for ischemia, viability, and AS detection. So this is the kind of patient where yes, you can do a PET, then next day you do PET viability, you do an echo, and then you do a stress echo for low flow, etc. Here you can get the whole thing. Takes longer, but it's only 40 minutes compared to 3 days. All right, so you see he has an infarction in the which territory? See the little red arrows? What's that? Inferior wall. Yeah, so yeah, small OM infarction. And here's the stress. And, this is a little bit nuanced, but, what do you guys think? Yeah, there is a sizable perfusion defect that extends beyond the size of the location of the infarction. And obviously, you have a patient with symptoms. One thing to look for when you're grading and identifying these perfusion defects, you want it to actually correspond to a coronary territory. You want it to extend through the series of images for multiple heartbeats. And it should have, just like with normal CAD, it should have a subendocardial to epicardial gradient. You can't have just like a weird epicardial defect and nothing else. That's not real. Does that make sense? So you still will apply all of the rules that you have for clinical assessment, whether it's echo and nuclear techniques when it comes to interpreting this. And he had the disease in the circumflex. He actually has a lesion in the RCA also. All right, I'll show you the cine images. So this is a 30-year-old, abnormal EKG, chest pain on exertion. What do you guys think? Yeah? Tell us more. So suspicious for HCM, right? There's asymmetric septal hypertrophy involving the anterior wall, the anterior septum, like extending throughout, and normal LV wall motion. Would you agree? Okay. Here's the scar imaging. What do you guys think? He has diffuse patchy scar. Notice all the way in the apex, anterolateral wall, mid segment, the basal segment, the septum. Notice this dense patchy scar here. Now, remember what I just said about CAD behavior. You think this is an infarction or non-infarction? So it doesn't have that typical wedge shape infarction pattern. It doesn't have the subendocardial to epicardial gradient. It's patchy, like you said. This one is hard to easily correspond to one specific territory. Notice how you get infraseptal wall. I'll show you more examples. And then obviously you have your pretest probability and your cine images. So this is kind of a typical pattern that we get for patients with hypertrophic cardiomyopathy who will also have perfusion defects that usually correspond to the areas of scar that's mediated by ACM. We used to do this regularly for SCM patients. It has an association with progression of scar. So if you get a 16-year-old with SCM, let's say I say, oh, his scar burden is now 6%. 10 years from now, it actually does progress in a group of patients, and obviously that's relevant. So we know that the presence of this microvascular ischemia due to myocyte disarray and coexisting microvascular disease in these patients, does actually associate with development and progression of scar. But we report this as more likely to be microvascular disease based on the pattern and appearance that I showed you earlier. This patient had a CT that didn't show any CAD, epicardial-wise. All right, so 74-year-old man, dyspnea, syncope, echo with increased wall thickness, and here's the scar imaging. What do you guys think? Healthy myocardium should be black. Yeah, he has scar throughout, diffusely, and notice that it's kind of mid-myocardial and extending. Usually, it's more so, this is kind of an extreme scenario, but it can vary. But, considering the history and these findings, I'll tell you the short answer to this is diagnostic for amyloid. So he had a stress test because it was ordered. What do you guys think? So stress on top, then rest on the bottom. So does that mean multi-vessel disease, do you think? Or yeah, I mean, even in multi-vessel disease, we don't usually see, perfusion defect everywhere. CAD doesn't behave this way, like Dr. Mamarian said. So when you get this kind of pattern plus the initial findings, the much higher likelihood is that this is microvascular disease related to amyloid, which we see known entity as well. And I believe he does have, coronary assessment that was normal. All right, so this is another case. I didn't put in the history. Yes. Huh. Yeah, good question. So we don't, fortunately, do apex slices for the stress MRI. We usually, at some point, and back and forth, we do a long axis series. Conceptually, it may be less likely because amyloid does have a gradient also where it's more in the basal slices and you get the apex varying. So there may be relatively less perfusion effect in the true apex, but I don't believe that's been looked at. Have you seen anything of the apex amyloid? Yeah, yeah, yeah. That would be interesting to see. And obviously, how this changes with therapy will also be interesting to see, but we don't know much about it. Yeah. Well, that you can't do with the MRI alone, but to label someone as Minoka, you would have to have them add an MI, add an anatomical assessment that did not show what you can demonstrate with confidence is obstructive lesion. All right. So here's one more patient. Um, he has concentric LVH. He has infarction in the distal apical inferior wall. There's also a small infarction in the diagonal territory, the anterolateral wall. And then I'll show you his cine. Sorry, I meant to flip these. So he has exertional chest pain, dyspnea, LVH, like I mentioned. Let's step back for a second. What do you guys think of the rest of the findings? Well, tell me first on this one. What else is there? I hear apical HCM. Yeah. He has global hypertrophy, but it is more pronounced in the septum. And then notice he also has SAM, right? See the flow acceleration through the LVOT. Um, So this is actually a patient with established HCM. HCM is not, you know, I know we say, oh, there's asymmetric septal and apical. The reality is, there is, not everyone will fit into the bucket completely neatly. So he has features of HCM, to say the least, and he has this LGE pattern. So is this LGE related to HCM or is this related to CAD? Sure, unsure? What do you guys think? Bridge, usually. I mean, unless extreme scenarios, wouldn't really give you an infarct. It would usually be an LAD infarct. Yeah, I mean, it has a typical CAD pattern, right? This is not a CM related LGE that we usually see. This could be a distal wraparound LAD, right? Or a distal PDA. And then this could be a diagonal lesion. We see these small infarcts, not. So people are allowed to have two conditions. Like I said, you can have a CM and CAD. All right, let's look at the perfusion. It's maybe, I think this is the last case, so I made it more. So this is stress, and notice this is, 4 series. So going from base to mid to second mid, and this is apical. What do you guys think? Do it the Almala way. Give me size and location and extent of defect, number of segments, SSS, SDS, whatever. Just start with it systematically. So what do you see in the base slice? Yeah, there's a defect that matches that tiny infarct, but is significantly larger, right? And extends through the mid segment, right? And then in the apex or apical lesions, there's a sizable defect also in the anterior, apical anterior wall, as well as the apical inferior wall and in the true apex as well, right? So taking into account the patient's LGE findings, what do you guys think this is? What's that? LAD only? Or could it be two vessel disease? Could it be multi-vessel disease? That's for that's yes, that part we can always say yes to. What about ACM? Can this be only ACM? Remember the other ACM case that I showed you. So the infarct pattern doesn't seem like ACM, although he may have ACM clinically. The extent of or the pattern of the perfusion defect does fit with 1+ coronary territory, and it doesn't have that heterogeneous patchy spots everywhere that you get with ACM. So this is more likely related to CAD, taking into all of this into account. Notice, by the way, he doesn't have, I think not that I can remember, but let's look now. Obviously, one thing that I didn't mention is you have to also be very careful with the wall motion abnormalities, right? So I didn't really get into that very much, but notice he has actually a wall motion abnormality here in the distal apical wall. Wouldn't you agree? I didn't show you the rest, but that also supports this. So he has LAD disease and he has a diagonal lesion, which fits, right? But you can also have, that diagonal lesion. The reason I say diagonal is notice it's anterolateral wall, anterolateral wall, but not so much in the septum, not so much in the anterior wall. So it can be proximal LAD, right? So it's diagonal plus either distal LAD, like I was mentioning earlier, or distal PDA, depending on how much, which one goes into the apex. Top left. Yes, that's actually a good pickup. I wasn't. It's been a while since I looked at this. Yeah, it's a small one. Yes. So I can't remember. Actually, I don't know if I recorded what he had on the RCA, but he has the diagonal lesion. He has a prior stent in the diagonal, the osseal diagonal, and then the LAD is, let's see, diffusely diseased without any focal lesion, although actually maybe in the distal apical LAD there is stenosis there. Would you agree with that? I'm not a cath person. You guys know. So yeah, I'm not sure about the RCA. Sorry, he may have, but yeah, I mean, this is to show you that you can have CAD plus SEM. All right, so this is the quantitative perfusion, and it has multiple, you know, physics-related techniques that essentially tries to get you parametric maps, one for stress and one for rest, and it has a gradient that also shows you mLs per minute per gram, just like you get with that. And you can look at the ratio of one stress to rest, and you get the absolute numbers. And like I said, there is more and more studies coming out about this. In this one, they looked at a group of 151 patients with multi-vessel disease, and they suspect or suggested that you could have better classification of disease or better identification of severity of disease with these parametric maps as opposed to just visual assessment alone, like we were doing the past hour. So, and this was predominantly when you have two vessel disease or three vessel disease. So this, I think remains to be more and more established. If you look at, the future slides that I've showed you and current practices, the majority is still based on visual assessment. With any, mapping technique or any, sort of derived image, you have to be careful in that it also can have errors and artifacts related to the source image. So if you're going to use this, you have to use this also. You can't just take a look at this map and say, click LAD disease, next scan. All right, so this is recent. So from the ischemia trial, as you guys know, the majority of patients underwent stress, SPECT, and echo to determine the presence of severe ischemia, although that was variable between the modalities. But there was actually a small subgroup that underwent a stress MRI. And as you know, this was followed by a blinded CT and then revascularization or medical therapy. So when this was looked at, they found in a small group 257 people who were actually randomized out of 313. So a vast majority were with SPECT and echo. One thing that they found is the rate of false negatives was actually lower with stress MRI. So as a result, people were more randomized more often, 82% versus two-thirds, 65% with stress echo and SPECT. And then the association between, let me see if I can zoom on this. The grading of ischemia by stress MRI was actually better from compared to stress echo and SPECT with respect to hard outcomes. So this is mild ischemia or no ischemia by MRI, this is moderate, and then this is severe. Notice in people with mild or no ischemia, they had virtually zero events. And then there was a very nice grading comes to severity of ischemia by MRI and the risk of events. When it comes to no or mild ischemia on echo and SPECT, there is that relationship still, but the gradient or that step up is a lot less pronounced. So even people with mild or no ischemia had events, right? So this is kind of some ways alarming, but this is what's found in this kind of initial study. Obviously, the ischemia trial wasn't comparing modalities directly, but when it comes to grading risk of events, it appears to be that it's actually better done with MRI. And this gets into the whole, better spatial and temporal resolution to actually identify disease and identify things like peri-infarct ischemia and the actual grade of ischemia. I should say, if you look at the entry criteria for all these modalities, they were actually highly different. So one required 3 segments to be dysfunctional, one required 10% of myocardium to be dysfunctional when it comes to SPECT. On MRI, they use 32 segments, so you divide each segment into epicardial and subendocardial, and they required 4 segments or higher to be significant. So in those who were assigned to conservative management with no or mild ischemia on imaging, the rates of those in the CMR group were significantly lower than those with the SPECT or stress echo. So imagine you get mild or no ischemia on stress echo and SPECT, and you end up with, a 30% event rate or 13% event rate when it comes to revascularization, uh, compared to virtually zero with stress MRI. All right. Now, this didn't include PET, so that will be interesting to look at. All right. So to conclude, MRI is a comprehensive, non-invasive modality that's very powerful for ischemic testing in kind of a one-stop shop, particularly in selected patients. Think about all your new onset cardiomyopathy patients, people with, coexisting disease that you also want to evaluate. If you're trying to avoid radiation in those, recurrent visitors, um, and you can get, detailed valvular assessment, vascular evaluation, things that you can't necessarily get with other modalities. And then it's recommended by the guidelines for virtually people with established or no established CAD. And it's preferable in things like MINOCA, uh, microvascular assessment along with PET. And then I didn't get too much into the financial aspect to it, but on a healthcare system level, it is actually calculated to be more cost effective compared to nuclear techniques in particular. And this is why you see stress MRI being done day and night in Europe compared to here. Um, and then it's non inferior, and actually, more recently, based on some of this ischemia trial, it may be superior. And then I will stop here. And hopefully, we get more quantitative perfusion. Questions? Yes. Uh-huh. This is highly variable, I think, based on the specific scenarios you went through. So if you're calling the valve team about, someone who you're thinking needs a TEER or needs TMVR, et cetera, they're going to want a CT, not because the assessment of disease severity is better with CT, but more for planning purposes. But when it comes to assessing, MR severity, AR severity, especially for regurgitating lesions, this is better done with MRI in terms of quantitative assessment. Now, if it's aortic stenosis, mitral stenosis plus, intervention purposes, CT plus echo may have an advantage. For stenotic valves, MRI can give you a very solid assessment, but you know, for these kind of planning things, that may be why they're telling you to get CT all the time. They have that habit now also. I should say also though, you can actually do a pre-TAVR assessment with MRI, and the reality is it's actually equivalent to CT assessment based on full-fledged randomized trial that came out 2 years ago. So we do these every once in a while in people who not get contrast at all, as in iodine contrast. Um, you can do this actually. Yeah. Anything else? Comments? Well, I want each of you to order one stress MRI over the next 6 months. Stop ordering pets on every single person that comes through the hospital. All right. Tell him I said that. Thank you.